So we are very happy to have with us again. It's nicer to have Parag in presence, but Zoom is nice as well. Thank you very much, Parag, for agreeing to do this. And the floor is yours.
Okay, terrific. Thanks for inviting me. I actually wanted to kick things off with a little bit of an embarrassing picture in my first ever experience with the Jerusalem Summer School. So this is a school that I participated in as a student. So this is a picture from the Dead Sea trip that we're unable to do in the Zoom era with my good friend Michael Ostrovsky in 2004. So almost 20 years ago. And I hope he didn't mind I show that picture, but what I want to talk about today is some work that I've been doing with my close friends and colleagues, Tayfun Sonmez, Utku Unver, and Bumin Yenmez. And I think one of the unifying themes of the talks in the last couple of days has been an aspiration for economists to be useful and constructive during COVID-19, whether it's Emily's dashboard or Michael's work with vaccine advance commitments. That's kind of where we started in this project. You know, the starting point for me was quite personal. So my wife is a physician, and back in March of 2020, she was going to the hospital and there was a great deal of uncertainty about COVID. And in particular, there was uncertainty as to whether if my wife got sick in the hospital, she would be first to get access to a scarce medical resource like a ventilator. And even at that time, there was severe scarcity of PPE like N95 masks. So that got me interested in Tayfun and Utku and Bumin as well in exactly what the protocols are when there's not enough of a particular resource. This is something that first started off with ventilators and ICU beds. It migrated to antivirals around May and June of 2020. And then by the fall, the conversation shifted to vaccines. So at the start of the pandemic, there was a tremendous amount of effort by various entities, state departments of public health, local regional hospital systems, particular hospitals to go back to guidelines that they had in their drawers on what should we do when there's not enough of a scarce resource, who gets it? The actual guidelines, which I'll tell you a lot more about, and the research on these kinds of guidelines are in the domain of bioethics or emergency healthcare medicine. And they focus exclusively on a priority system as the allocation mechanism. So in a priority system, there is a single ordering of patients. Whoever is first in the priority order is awarded a unit, and the system proceeds in priority. In some cases, there are priority tiers, which are course priorities. That's something that is quite common with vaccine distribution. So what I want to tell you a bit about today is why we think a priority system is often too restrictive of an allocation mechanism. And that's going to be an argument I'm going to make based on just practical debates that we've seen in the field. So I'll take a little bit of a detour and tell you a little bit about medical ethics. And the second thing I want to do is propose a reserve system, which is a generalization of a priority system as a more flexible alternative. Okay, so I'll define that precisely. In fact, the paper that this is based on actually develops a general theory of reserve system design. So I'll tell you a little bit about some of those details. And I want to spend a decent amount of time talking about some of the recent policy debates and some of the policy developments, because it's been quite instructive interacting with different communities. And I think this is a place where economists have a place at the table, and that hasn't been how it's been historically. Okay, so let's start off with a little bit of an introduction into medical ethics. And I want to jump to a pair of articles that were published in the New England Journal of Medicine in late March 2020 that really brought the discussion on allocation of scarce medical resources to broad attention. So there was an article by Zeke Emanuel, who is a prominent bioethicist at University of Pennsylvania, and an article by Bob Truog, who we'll tell you a little bit more about today. And both of these articles shine the spotlight on guidelines and the urgent need to revisit or, in some cases, actually issue guidelines on allocating medical resources. And in the Emanuel et al. Paper, the article talks about various ethical principles that should play a role in determining who gets allocated the scarce resource. And Emanuel's paper, as well as many other guidelines, including earlier guidelines for influenza pandemics or recommendations from the World Health Organization or international organizations like SAGE, often begin by articulating ethical goals. Okay, so on the slide here, I have some of the most common goals. One is saving the most lives, or a variation on that, saving the most life years. These are kind of utilitarian principles. Another principle that's often discussed is what's called the life cycle principle. That is often described colloquially as the fair innings approach. Everyone should have the opportunity to play in all of the innings of the game of life. Instrumental value is a principle that is trying to recognize the concerns of those who are instrumental for keeping society functioning. So this includes, say, frontline medical personnel, or a broader concept of instrumental value. Our essential workers should get some kind of prioritization. Reciprocity is a backwards-looking principle that thinks about prioritizing or giving units to individuals who have taken risks in the past. So that would be, for instance, my wife, who had to go to work with an N95 that we happen to have in the basement of our house for a pretty random reason. And then lastly, another principle that's often discussed is equal access or non-discrimination. We shouldn't discriminate against individuals based on race, ethnicity, caste, or the presence of disabilities. So disabilities rights advocates often talk about equal access. Now, interestingly, there is a pretty widespread consensus among medical ethicists that allocation should not be based on income or willingness to pay. They find that unacceptable. And in most situations in the United States, there hasn't been allocation based on who's willing to pay the most. Now, of course, that's hard to often always insist upon. And some countries have experimented with allowing people to pay for vaccinations. So that's something that's been taking place in India until recently. The government in India has now said we don't endorse using a price-based allocation system. So you can imagine when you have all of these competing goals, the allocation planners need to come up with a way to arrive at a balance between these objectives. And so, for instance, if we say there should be equal access, that might suggest a system like random allocation. So certain disabilities rights groups have criticized protocols, and for instance, the Alabama protocol was seen to be discriminatory against patients with severe disabilities. Equal access is not going to take into account patient age, whereas life cycle principle explicitly takes into account patient age. Okay, so the task before allocation planners is to arrive at some kind of compromise between these different goals. Okay. Now, in some of these ethical principles, the challenge of arriving at a compromise is not so large. In some cases, only the individual attributes of a patient are relevant. And there may be natural or well-established cardinal measures of the criteria. So for instance, for the life cycle principle, age is natural to consider. For saving the most lives, which is something that's often discussed for ventilator and ICU bed allocation, most of the guidelines that I've seen focus on a medical metric that's called the SOFA score. SOFA stands for the Sequential Organ Failure Assessment score. And that's a metric that's been devised over the years by clinical care medicine communities and ethical communities. Essentially, the SOFA score numerically quantifies the number and severity of 6 organ groups. Okay, so lungs, liver, brain, kidneys, blood clotting, and blood pressure. Each of those organ groups is assigned a score of 1 to 4. And the higher score that you receive, the more severely failed your organ is. Okay, so they take these 6 different organ groups and then they aggregate it by summing across the organ groups. And that's something that I'll show you in the field in Massachusetts. The SOFA score is used for ventilator allocation in just a second, okay? So let's now turn to some other examples that are in the field and think about the potential limitations of a priority mechanism, a priority system. So as I've mentioned, the benchmark allocation system used worldwide is based on variations of a priority system. Okay, so we have coarse versions based on priority tiers, like what we've seen for vaccine allocation, and then we have explicit numerical scores, what we call priority point systems, used for more specific medical resources like ventilators and ICU beds. Okay, so back to the SOFA score. Now, there is a fair amount of literature trying to demonstrate that the SOFA score is a good proxy for mortality risk. Okay, so if the sole ethical value under consideration is the utilitarian goal of saving the most lives, then a natural starting point is to have a single principle priority point system based on the SOFA score. Okay. Now, if there are multiple ethical values, then a priority point system may restrict the ability to arrive at a ethically compelling balance between values. And why is that? Well, a priority system is taking an individual attribute and mapping it to a numeric scale. So if there are ethical principles that lack a cardinal representation or even lack a monotonic representation, we may have to think about more flexible alternatives. Okay, and so for instance, if we had a consideration of gender diversity, what we would need to think about is a more general version of a priority system. In the case of COVID, one of the big considerations is the need to prioritize disadvantaged groups who have been proportionally hit hard, much harder than other groups in COVID case counts and COVID death rates, right? So in the United States, as of April, Blacks were dying at 1.4 the rate of whites in the United States. So the concerns for disadvantaged groups was something that was definitely on the minds of a lot of allocation planners. Now, the fact that we need to potentially consider values beyond just saving the most years of life is something that there is widespread discussion on in the documents that describe these allocation guidelines. So they recognize, the desire to consider multiple ethical values, but many states adopted a priority point system based only on a SOFA score. Okay. Now, the examples here. Yeah.
Could I ask you about the SOFA score? So it seems that even there might be a conflict between saving the most lives and taking people with highest SOFA score or lowest SOFA score first. If you want to save the most lives, you might not want to treat the sickest people first because they're probably going to die anyway. So you might do something more complicated than that.
Yeah, so that's absolutely right. And actually, one of the reasons the SOFA score is very controversial, Eric. So you're right to kind of ask about this. So one point that you made is completely right. Is this actually going to save the most lives? A reason I wanted to show you this one is not only that it's very common, but they've also had to aggregate 6 different organ groups and come up with a single index. And it's not really clear that the scoring that they use, right? So, the scores are 1 to 4, are directly relevant for the likelihood that you would die from COVID. So blood pressure, for instance, may not be a comorbidity. So that's a second kind of criticism of SOFA. A third criticism of SOFA actually relates to the fact that certain demographic groups in the United States are predisposed to have lower SOFA scores because of their demographic characteristics. So in particular, African Americans systematically have lower SOFA scores on liver and kidneys. And so by using a SOFA-based metric, we might already be baking in some bias. And in COVID in particular, the aspiration of many planners was to kind of actively combat that kind of bias. So that's something to keep in mind. I'm going to show you in just a couple of slides, Eric, how Massachusetts took SOFA and then added a couple of things to it to try to balance the saving the most lives idea with a couple of other goals that they had. So let me come to that in just a second. And that's actually going to be in my next slide. The point that Eric is making about SOFA maybe not even accommodating a single value is discussed in the literature, but there's another branch of literature that says, well, we shouldn't use a single principle even to dictate what we're doing. We should use a multiple principle priority point system. Okay, so the idea there is we're going to take different ethical values and we're going to map them to numbers, and then we're going to sum it up to come up with a priority ordering. Okay, so the most famous advocate for a multiple principle priority system is Doug White, actually. He's a professor of clinical care medicine at the University of Pittsburgh Medical Center. And multiple principle point systems were adopted in states like California and Massachusetts. So this is an example of a multiple principle point system. Okay, so our first row has an ethical principle. So this is literally from a table used in Massachusetts, okay, for their ventilator guidelines. The principle that's articulated here is save the most lives, okay? And the specification is this is a prognosis for short-term survival. The SOFA score is coarsened into 4 point ranges. If your score is below 6, you get a point of 1. If your score, say, is above 12, you get a 4 points. Next principle is save the most years of life. Okay, so that's also kind of like a utilitarian principle. And this is also partitioned into 4 groups. Whether you have any comorbidities, whether you have minor, major, or severe comorbidities. And lastly, we have the life cycle principle. So the current version of Massachusetts guidelines actually eliminates the life cycle principle, but the initial guidelines had this third row where we have points for age. So if you're 75 or 74, if you're 75 or greater here, you'll get 4 points, whereas if you're between 12 and 40, you only get 1 point. Okay, so we take these different dimensions, we sum them up, and whoever has the largest value would be allocated a ventilator first. Okay. So you can imagine, yeah, please.
So wait, so we are more likely to give a ventilator to an older person who is likely to die within a year? Am I getting that right? Or is this?
Yes, no, that's right. Yep. So we would say your SOFA score, if your goal is to save the most lives, you should get a ventilator. If your SOFA score is really high, if your organs are about to fail, if you're old, and if you have comorbidities, severe comorbidities.
Okay.
Yep. You
Does
may
the
like that, Michael.
say it
Yeah.
again?
You sound like you're uncomfortable with that.
I'm a little intrigued by it. I'll tell you that. It kind of reminds me, down in Louisiana, we had a couple different ways that you could try to get a vaccine. And one of the ways that they eventually put on was if you were a smoker, you could get the vaccine. And this is kind of reminding me of that. So I put down that I was a smoker at the time because I didn't know how they were going to check that, so I could get a vaccine. But it just seems incentivizing some of the weirder things. And I'm confused how the life cycle principle works in this. So we want the older people to get saved first, but doesn't that go against wanting to save the most future years?
Yeah, so this is, if you look at the document, there's lots of discussion about the infection fatality rate for COVID, for instance. So it's much lower in these lower age groups. So that's, I think, factoring into this prioritization for age 74 or greater. So I also, they also took this one out, Mitchell. So I think, I've never been in one of these meetings. I think it would be fascinating to be a part of one of these meetings. The experience that we learned about is, and I'll come to this towards the end, we were involved in working with the University of Pittsburgh Medical Center with Doug White, actually, on setting these criteria. And the way they do that for a hospital center is through community engagement. So they go out and amass a group of people who are community stakeholders. That includes clergy, that includes, representatives of, say, disadvantaged groups, disability advocates groups, and they hash it out. They have to come up with a system. So most of the systems that we see are a result of that kind of conversation. So let me keep going. Okay, so priorities. Yeah.
Can I take you back a second, because I'm confused. So I'm just repeating the question that Michael put. Can you go back to the slide? Yeah.
Yeah.
So, my intuition says that the lower is the aggregate number of points that you get, the higher should be your priority. You're saying the opposite?
Let me make sure I'm saying this right. So why are you saying it's lower should be higher priority?
Well, for example, if, as far as I understand the life cycle principle, if you're older, you get less.
Oh no, I think I've misspoken, Elad. I think I've misspoken. You're right, actually. So I'm saying this the opposite way, right? So if your goal is to save the most lives, you should give it to folks who have good organs. SOFA score is low. If you want to save the most years of life, you should not give it to people who have had heart attacks or other comorbidities or immunocompromised, right? So, right. Yeah, so I'm sorry, I misspoke. It's the opposite. You're right. You guys are right. Yeah.
Just to make sure I follow the third principle as well, the life cycle principle, as far as I can understand it, favors younger people, right?
Yes, yeah, that's right. Because you want to let younger people go through all the fair innings of life. Exactly. Yep. I'm so sorry about that. That's a mistake. Great. Okay. Okay. So a priority point system or priority system more generally is restrictive because it allocates all units based on a single priority ranking, sometimes by mapping individual attributes to a numeric scale. And as I've mentioned, some principles may not have a monotonic cardinal representation. Other principles, especially related to equity, may depend on the group structure. There's an issue of aggregation across ethical values. So we have to take a stand on comparing different values numerically. So in the Massachusetts guidelines, they had a special discussion about pediatric patients and the adequacy of SOFA scores for pediatric patients. So there's a lot more uncertainty of the predictability of SOFA scores vis-a-vis mortality risk for pediatric patients. But what they actually ended up doing is applying essentially that same table to pediatric patients. And so that's one version of what ethicists call the problem of incommensurability. And I want to illustrate this challenge with the debate on essential personnel priority for ventilator allocation. Okay, so on this specific ethical goal here, many have argued that essential personnel should receive priority. Okay, so this is discussed in that Zeke Emanuel article that I mentioned earlier. And medical ethicists talk about this. And in fact, many guidelines talk about various reasons why we'd want to prioritize essential personnel. So one is the backward-looking principle of reciprocity. So that's the story of my spouse going to the hospital and bearing risks. The forward-looking principle of instrumental value. Patients, essential personnel, medical personnel are needed to keep society functioning. Another argument that's discussed is more of an economic argument based on incentives. So the concern about sick outs. Okay, so this is something I have an older sister who's an emergency room physician, and she said this is a real consideration. If emergency room physicians are putting their lives on the line and they don't get access to a ventilator, they may just call in sick. Okay. Now, I don't know how widespread that is, but it's certainly something that occurred to many people. If we talk about the debate on prioritizing essential personnel, one thing that we saw early on in March and April is that states were very vague about essential personnel priority. Okay. And so Massachusetts initially recommended that table that I just showed you. And if you look at the text underneath that table, it says there should also be heightened priority for essential personnel. So it's a little bit odd to us that we have specific numeric scoring for different patients based on these particular rules. But then when it comes to essential personnel, there's kind of a throwaway line saying, oh yeah, essential personnel should get heightened priority. In Pittsburgh's guideline, they had a similar kind of table, and they said we should have two tiebreakers. So if we have two patients that have the same exact score, we should have two tiebreakers, one based on age and the other based on essential personnel status. But there was no details on exactly how to use these tiebreakers. And the vagueness in these cases sharply contrasts with, widespread consensus that if you're going to have a guideline, it should be as precise as possible. Okay. And in particular, you should have the ability to have a patient advocate get explained why they didn't get the resource. Okay. What were the exact procedures that were used to get the resource? I think I missed a question. Was there a question?
Yeah, I was gonna ask a question. I don't know if this would be better for you to answer here or somewhere else in your slides, but I'm quite curious if in any of these, maybe it's a little taboo, in any of these discussions, if the flip side of the reciprocal principle is ever used. So you look at, well, you have some people wearing masks, distancing, and then you had other people who would not wear masks, who wouldn't distance, who maybe didn't get vaccinated now that we're having the vaccines out. And there were some people in my circle who maybe a little controversially would say like, well, I'm wearing a mask. I don't think that person who is partying all the time and now is sick should get a mask over me. Has there been any discussion of that, or is that a little bit too controversial, a little too taboo, kind of the negative principle of this risk?
Yeah, I think it's a lot of people share your feelings, I think, about, not mitigating and taking appropriate precautions. I don't think anyone has seen using these schemes to punish people, to create that kind of incentive. On the affirmative side, there definitely is discussion that, and this has happened in many places, folks who, participated in vaccine trials should get priority. So that encourages, good behavior, you could say. So you get compensated for that. But on the negative side, I think people are allergic to that punishment idea. I see another question.
Since we've stopped for a little while, I'd like to ask, because I've noticed somehow cultural difference between accepting such judgments based on scores. So doesn't it affect such scores whether the patients in general would accept such decisions or protest against them? So I've heard that, for example, in the UK, if the physicians told you that no, you wouldn't get this ventilator, that's it. But I don't know, I'm Hungarian here, it was taboo saying that the physician would tell you that no, you wouldn't get it. So doesn't it have a cultural impact to create such schemes, or have you delved into this topic?
Yeah, that's a very good question. I'm sure the criteria that are used depend on the local context, especially because of the way these criteria are implemented through stakeholder engagement. There is this idea that within the United States, some of the states that are, you could say, more conservative or more laissez-faire, were more likely to emphasize just speed, getting vaccines out over prioritization, whereas the more like left-leaning states put a greater emphasis on equity for vaccine allocation. So, the states that targeted hard-hit areas tended to be a little bit more on the left side. There are, of course, exceptions to that. I would imagine you'd see something similar, but there's not much research on that. So most of the bioethics research on this is just reviewing kind of how to do stakeholder engagement. But I've never seen a study that says, how would we expect the differences to vary by cultural context? Great. Okay. So, yeah.
Let me ask a more down-to-earth question, less philosophical or
okay.
less high level. You talked about vagueness. Now, is the notion of what is it? The personnel, essential personnel. Is that uniquely defined? Is that
another fantastic question? Is that Ron?
Yep.
Yeah. So that is a massive debate in the United States. Who is essential? Okay, so this just shows you how ethically fraught these questions
it includes me. That's right.
Yeah, sir, you're right.
That's my definition. Yeah. I mean, of course, it's very subjective. Yeah,
it's super subjective. State departments of health have defined essential personnel. Ranging from that should include folks who deliver mail or deliver packages to other definitions that are these should only be the doctors who are facing COVID patients. So if you're a dermatologist, a skin doctor, you are not essential. So there's a very, very wide spectrum. In fact, there's a paper that Chris Avery and Amitabh Chandra published in JAMA in the summer, looking at some of these definitions, and they showed that the range of patients who would count as essential personnel is, could be all the way up to 60%. I
also experienced that it was dynamically changing. That, for example, when they realized that like 50% of the subway drivers are out, they've realized, oh, we need subway drivers to this country to go, also with teachers or stuff. So it was dynamically changing this essential worker part, no?
That's right. So, there was a fair amount of discretion given to the actual allocators in the end to determine, and this kind of relates to the smoking conversation, how are we going to actually check some of these attributes? And so there's wide variation on that. So one other kind of anecdote. So MIT's vaccine allocation system, they decided essential personnel are anyone who's a groundskeeper. Okay, so if you're coming to campus and you're cutting the grass and keeping the facilities, you're an electrician on campus, you will count as essential personnel. And that, how did they come to that conclusion? Well, there was a committee, so I was loosely a member of this committee, and HR at MIT strongly advocated that this group should count. And that's how these decisions get made in practice. So back to essential personnel, okay? And I'm going through this just to illustrate, the challenge with a priority system. So Massachusetts guidelines discuss that a preference is given to medical personnel based on, that sentence following the table saying there should be heightened priority for essential personnel. In Pennsylvania, there was an article that came out a couple of weeks later that says, I helped write Maryland's ventilator guidelines. Pennsylvania's rules are too vague. Okay. And the vagueness and confusion about this issue is something that we've seen even pre-COVID. Okay. So if you look at some of the discussions about influenza pandemics, there is a debate about essential personnel. And so in the Minnesota guidelines that were written in 2010, okay, so this is well before COVID, there's a line in their guidelines that say it is possible that essential personnel, would use most, if not all, of the short supply of ventilators, and other groups systematically would be deprived access. In New York's discussion, also about influenza pre-COVID, there is a line that says essential personnel priority may mean that only healthcare workers obtain access to ventilators in certain communities. This approach may leave no ventilators for community members, including children. This alternative was unacceptable to the task force. So both New York and Minnesota did not have essential personnel priority, and they're worried about these two extreme cases where we run out of ventilators and are only able to satisfy essential personnel. So limitation of the allocation mechanism resulted in giving up some of the values that both New York and Minnesota saw as important. Okay, so this is kind of our opening to think about, could we have a more flexible alternative? And the alternative that we propose that's a little bit more flexible, so a kind of generalization of a priority system, is what is known as a reserve system. Okay, so it's clear that many of the challenges of the priority system are coming from the restriction of a single priority ranking of patients. Okay, so what we need to do is think about breaking this property. Okay, and that's what a reserve system does. Okay, so a reserve system takes the supply of resources and divides it into multiple categories and allows for potentially distinct criteria for allocation of units in these different categories. Okay, so if we had just one category, we would have a priority system, but if we have multiple categories, we can use different prioritizations within those categories. So for instance, we could have a set aside or a reserve for essential personnel. Some portion of units are going to be reserved for them. What that means is they will get priority over other patients, but that won't apply to all of the units. Okay, and so these category-specific criteria allow for more flexibility to balance ethical values. Okay, so reserve systems are often used in resource allocation problems where there are these competing factions, competing goals. In medicine, the only other time we've seen a reserve system used is for deceased donor kidney allocation. So a couple of years ago, the United Network for Organ Sharing specified a reserve system with two categories, higher quality kidneys and other kidneys. A reserve system is actually used for the allocation of slots in the Boston and New York City Marathon. Okay, so, there for the New York City Marathon, if you only awarded slots to run the marathon based on time, people would have said that's not really fair. That's going to just be for fast people. So what they've done is they have different categories based on your age, and then they award you based on your time. Okay. A reserve system is used for immigration visa allocation in the United States. So there's two categories. There's a category for immigrants who have advanced degrees, and reserve systems are used in higher education and in K through 12 for affirmative action systems. Okay, so that's in several cities, and I'll tell you a little bit more about those. So what are the primitives here? Okay, so one of the interesting things about this project is the word reserve system created a very harsh reaction from some of our medical friends, because there was a concern that you're going to be reserving units and not deploying them. Okay, so you're leaving units idle. And how could you ever imagine not using a ventilator when a patient shows up who needs a ventilator. Okay, so our friends recommended that we call it a categorized priority system instead. Okay, and basically, it's a very descriptive title because we have these categories. Okay, so that's the first primitive, a division of the total supply of resources into multiple categories. We have the size of each category, and then a category-specific priority order for individuals in each category. Okay. Now, the last thing that we need to think about is in most applications, it's necessary to think a little bit about what happens when an individual qualifies for a unit through more than one category. Okay. Now, for our problems, the units are identical, so the individual doesn't care. They only want to get the unit. But by allocating them a unit from one category versus another, that can influence the outcome for other individuals. Okay. And this last point is something I'll spell out in a little bit more detail shortly, but it's something that's often misunderstood in real life applications. Okay, so this is something that we've studied with Umut Dur and Scott Commoners in school assignment, and also with Alex Rees-Jones and Typhoon Sonmez for H-1B visa allocation. So let me tell you a little bit about the general theory of reserve systems that we developed in this paper. And the plan is the following. So I don't really have the time, I think, to get to all of these details, but let me see how far I can get. So I'm going to start off by formulating what we think of as 3 intuitive axioms for pandemic resource allocation and examine the implications of these axioms. We're going to relate these axioms to what we call a cutoff equilibrium solution concept. And that allows us to bridge axioms to real life applications. Then we'll talk about a specific class of reserve procedures that we call sequential reserve matching policies. These are the dominant real life applications of reserve systems. And then we'll talk about a potential shortcoming of a sequential reserve matching policy and introduce a remedy that we call smart reserves. Okay, so I'm going to spend a little bit of time on this, and then I want to come back to some of the policy work that we've been doing. Okay, so here's the setup. Okay, so we have a finite number of patients denoted by I, and they each need 1 unit. Okay, so this is abstract. When we talk about specific resources, there's going to be particular considerations, ventilators versus vaccines, for instance. Q is the number of identical medical units in short supply. Okay. C, script C, is a set of reserve categories. And R sub C is the number of units subject to category C allocation criteria. Okay, so that's the partition of the units into those for a particular category. Next, we have a priority order of patients for units in category C. Okay, so that's, for instance, where the SOFA score could come in, or we could use a lottery-based criteria. And the notation is the following. I is prioritized for category C over patient J if I pi C J. We'll say I pi C empty set denotes patient I being eligible for category C. And lastly, a patient's ineligible if the empty set is given priority over patient C. Over patient I, that's a typo, for category C, okay? And then pi underscore C is the weak order induced by priority pi C, okay? So what's going to be an allocation here? We'll denote it using matchings. Okay, so a matching is a function that maps patients to categories or the empty set such that no category is assigned to more patients than the number of its units. Okay, so patient I, mu I, will be the matching for patient I, and they can either be matched to category C, which means they get a unit, and they get a unit reserved for category C, or they're assigned the empty set, which means they're unserved. Okay, so you might be wondering, why do we need to specify how a patient receives her assignment? After all, a patient wants the unit versus not having the unit. And the reason is what I mentioned just a second ago. The category through which a patient receives a unit has implications for other patients. Okay, so even though patients are indifferent between all of the units, their claims over units in different categories may be different. My claim for an essential personnel category depends on whether I'm essential personnel or not. Okay, so that's why we have to keep track of this. Okay. All right, so that's the basic setup. Now let's talk about the axioms. Okay, so first, I'll say a matching complies with eligibility requirements if patients only receive units from categories for which they are eligible. Okay, so just in terms of the notation that we just introduced for all patients and for all categories, if patient I is matched to category C, then patient I must be eligible for category C. Next, we'll say a matching is non-wasteful if no unit from any category remains idle, despite the presence of an eligible patient who remains unserved. Okay, so this is also quite intuitive. For any patient in any category, if patient I is eligible for category C and patient I is unmatched, it must be the case that there are no idle units in category C. Okay, so mu inverse of C are the units assigned in category C that has to equal RC.
So, and what's important there is that you say eligible patient. So if you had someone who did not fit in any of the categories and you had 20 ventilators, but you weren't giving it to this person, it would still be considered non-wasteful.
Correct. Yeah. So there are some states that say if your organs are severely failed enough, you will not get a ventilator. It's not worth it to deploy a ventilator for you. Exactly. And the last axiom is respects priorities. So matching respects priorities if no patient remains unserved while a unit from some category is awarded to a lower category patient for that category, right? To a lower category C priority patient. Okay, so just in terms of the notation, take two patients, I and I prime, and a category C. If patient I is awarded a unit from category C and patient I prime is unserved, then it must be the case that patient I has higher priority for category C than patient I prime. Okay. Okay, so those are the axioms. Now let's think a little bit about the implications of these axioms. What I want to do next is introduce a counterpart of competitive equilibrium for our model, okay, that we're going to call cutoff equilibrium. Okay, so the way we're going to do this is we're going to define cutoffs for each category. So the notation is F sub C, and the cutoffs are going to be defined in patient space. Okay, so cutoff FC is an element of I in the empty set, okay, such that FC is the cutoff individual, okay? You'll see this is kind of like thinking of a non-negative price, okay? Once I have the cutoff for a given category, I can define the budget set for a patient by looking at all of the categories that patient I is given a weekly higher priority for than the cutoff individual, okay? So that's the budget set, BI. And now that we have the budget set defined, we can define a cutoff equilibrium, okay? So like competitive equilibrium, we have a price and an allocation. Here, that's a cutoff vector, a cutoff for each category, and an allocation, a matching, such that first, for every patient I, the assignment of patient I is in the budget set or the empty set, okay? So you're getting assigned something that is in your budget set or the empty set. Second condition here is if your budget set is non-empty, then patient I is assigned to something in the budget set, okay? Second condition is more of a market clearing condition. Okay, so that states for any category C, If I look at the number of units awarded in that category, and if it's less than the size of the category, RC, then the price here, the cutoff individual, FC, is the empty set. Okay. Okay, so this is a formulation of a competitive equilibrium for our model. And now we can talk about a cutoff matching. So a matching mu is a cutoff matching if it's supported by some cutoff vector F at a cutoff equilibrium. Okay, so why am I doing this? Okay, why am I introducing cutoff equilibrium? Well, I want to relate these axioms to real life applications of reserve systems. Okay, and pretty much every place that we've seen a reserve system, we've seen it described through its cutoff equilibrium. Okay. Now, the one difference between what we've done is the usual way the reserve systems are, the cutoffs are defined are in terms of the cutoff priority, not the cutoff individual. Okay. But just for example, in the reserve systems used in affirmative action systems in India, the outcomes are often represented through the cutoff exam scores for the various castes that get affirmative action. In the affirmative action system used for Chicago's exam high schools, they report the cutoff scores needed for the different reserve categories. And in visa allocation in the United States, that every year they report cutoffs based on the application arrival date. So that's for the years 2005 through 2008. So just to show you, these are examples. On the left here, I have the cutoffs that are given in the Rajasthan public service allocation system. The rows here are the different categories: general category, scheduled caste, scheduled tribe, your general, whether you're a female, so on and so forth, and you can see what the score you needed there is. On the right is the Chicago system, where there are 4 different tiers for each school based on where you live, and the cutoffs are represented here for each of those 4 tiers across the schools in Chicago system. Okay, so we see the cutoff equilibrium ideas in the field, and our first result is to show a link between our 3 axioms and the cutoff equilibrium solution concept. Okay, so our first theorem is a matching satisfies our 3 axioms. It complies with eligibility requirements. It's non-wasteful and respects priorities if and only if it's a cutoff matching. Okay. Now, let's say a little bit more about cutoff equilibrium properties. So for each cutoff matching, we can define a minimum cutoff vector and a maximum cutoff vector. And every vector F in between the minimum and the maximum is also a cutoff vector. And what we're going to do for the remainder of the talk is focus on the maximum cutoff vectors. The way we'll define that is for any category C, we'll look at the lowest priority for that category, the lowest priority patient for category C, matched to the category if the units in the category are exhausted. Okay. If they're not exhausted, we will set that to be the empty set. Okay. So that's the maximum cutoff vector. In the paper, we talk about other cutoff vectors. We think the maximum cutoff vector is the one that has the most intuitive appeal because it tells us about the selectivity of the category. That is, the higher priority the cutoff patient is, then the more competitive that category was. Okay. So let's press ahead and talk about a specific class of reserve systems that we call sequential reserve systems. And in general, a reserve system doesn't have to process categories sequentially, but most real life practices do processing of these categories sequentially. So let me introduce notation for the processing of a category, what we call the order of precedence. C precedes C prime if category C units are to be allocated before category C prime units. Okay, so in a sequential reserve matching, we'll fix a processing sequence of the categories. And following this sequence, we'll allocate units in each category C to the highest category C patients up to capacity. Okay, so let me show you an example of this. Okay, and so I have an example where I've taken our ventilators and we've created an open category. So that's open to all patients, and then an essential personnel reserve category. Okay, so the blue line here represents the general community of patients. Okay, and the red line here represents essential personnel. Okay, and the way to read this is the patients here are ordered in priority. On the left are patients with higher priority. Okay, so let's imagine that we process the open category first. What's going to happen here? Well, in the open category, both general community patients and essential personnel will compete for slots, and they will be awarded in order of their priority. Okay, so since there's an equal number of general category and essential personnel patients, the open category will be divided evenly between those two groups. Okay. Next, what happens? We move on to process the essential personnel reserve category. In that category, essential personnel get preferential treatment over general community patients. So that entire block of units will be awarded to essential personnel. And so this is the final outcome. This is what the literature has now been calling an over and above reserve policy, because essential personnel get a bite of the open allotment, and then they get an additional reserve over and above the bite of the initial allotment. Okay. So this is what we see when we process the open category first and then the reserve category second. Let's think about doing the opposite sequential reserve policy. Okay, so here we're going to process the essential personnel reserve first. So the red guys will be awarded that block of red units in order of priority. Then we turn to the next category, the open category. And here we award patients in order of priority. So who's left at this stage? We have the highest priority general community patients, the blue guys, okay? So they're gonna take the next chunk of the open slots, okay? And then finally, we end up with an even pool of general community and essential personnel patients. So that remaining block of open will be divided evenly between the GC and the essential personnel patients, okay? So what you see here actually is, in this example, which the literature has now started to call a minimum guarantee policy, the allotment of units to essential personnel is identical to the allotment of units to general community patients. Okay, so surprisingly, perhaps, we have an essential personnel reserve, but we would have the same exact outcome without a reserve at all, right? Because it would be exactly split half and half. And that's what we see is happening here. It's split half and half. Okay, so this is called a minimum guarantee because we've guaranteed that essential personnel at least get an amount according to the essential personnel reserve. Okay, so a couple of things to learn from these two examples is, first, there can be several cutoff matchings. Okay, so if you think about the max cutoff, remember that's the lowest category C patient to be matched to category C. It depends on how exactly the reserves are processed. Okay, so the processing sequence of categories is going to be important. And as we just talked about with a minimum guarantee, sometimes reserves may be redundant. Okay, you may not actually need a reserve if your goal is to implement a minimum guarantee policy. I see a question. Is it Mitchell? Michael? I think you're muted.
Ooh, yeah. I'll be quick because I know I've been holding you up a good bit. So would the results of that thought experiment there be drastically different if we didn't have 50% of the population was essential workers?
Yeah, what would be different is this last point here. So with this exact balance between the two groups, the example works out such that the minimum guarantee is irrelevant. If we had a different share, we had more general community than essential personnel, that wouldn't necessarily be true. But the processing matters, and the multiplicity is something that's generic. Great. Okay, so so let me develop a couple more results. So I'm gonna have to go a little bit faster. Okay, so one thing that we can observe is in this model, if we have a processing order denoted by this triangle prime, and we compare it to another order of precedence, where the only difference is that we process a category C earlier in the sequence, but otherwise we keep the relative processing sequence of all other categories the same, then the max cutoff for category C under the outcome from the primed order of precedence will be weakly higher than the max cutoff for category C under the original order of precedence. Okay, so what does this mean? This means that the earlier a category is processed, the more selective it becomes. Okay. And where selectivity is based on this cutoff concept. Okay. So let's now specialize the model even further. So I said in the field we see sequential reserve processing. We often see a further simplification where we have a baseline priority order. Okay, so what does that mean? This means there is a general category, what we often call an open category, but here I'm calling it an unreserved category. U, which has a baseline priority pi of U, okay? And any other category C provides preferential treatment to a beneficiary group. Okay, so if we had a essential personnel category, the beneficiary group are essential personnel, okay? And the prioritization pi C for that category will prioritize beneficiaries of category C over others, and use the underlying baseline priority pi U to break ties, okay? So for any patient who is a beneficiary of category C, we then turn to pi U, and for any patient who's not, we turn to pi U. Now, there is a distinction between what folks call hard reserves, okay, which are systems where eligibility in a category is restricted to beneficiaries only, okay? And soft reserves, that's a system where everyone is still eligible. If there's not enough essential personnel in the essential personnel category, we'll let general community patients take those units, okay? Lastly, let me define the set of general community patients, IG, as those who are beneficiaries of only the unreserved category. Okay, so that's the notation there. It's all patients, take away the patients that are in a beneficiary group. Okay. So when we have this baseline priority, this structure, we have another result that's the following. So consider a reserve system with hard reserves and let an order of precedence, caret prime, be obtained from another order of precedence by processing a specific category earlier in the sequence, okay? But otherwise, we're going to keep the relative processing sequence of all the other categories the same. Then if we look at the set of patients who are matched from category C under the prime precedence, it's a subset of the patients who are matched under the original precedence, okay? So what does this mean? It means that we can take our earlier result, which was formulated in terms of cutoffs, and look specifically at the beneficiaries of a particular category. And it's a pretty similar theme here. Under hard reserves, the earlier a preferential treatment category is processed, the worse it is for its beneficiaries. Okay, so if we want to have essential personnel get those units, we think about the over and above implementation where they're processed at the end, right, rather than at the beginning. Okay. Now, it turns out this result is true under hard reserves, and it holds for a version of the soft reserves problem, provided that there are most 5 categories. Okay, so if we have at most 5 categories and each patient is a beneficiary of at most 1 preferential treatment category, this is true. It turns out, and this is kind of some of the weird things that can happen in these kinds of problems when you have 6 categories. We have a counterexample. It's quite involved. It may not be that realistic, but this theorem is no longer true. Okay, so there's these chain reactions that can happen. Okay, so just kind of summarize where we are with the theoretical development. With the over and above implementation, a reserve category is processed after the open category, and that is over and above. It's providing the stronger benefit to the category. And this may be best suited for situations where we want to have a reserve provide an extra boost to a particular group, okay? And this is what we've seen used in the field in India and in Chicago and for H-1B visa allocation. The minimum guarantee implementation is one where the reserve category is processed prior to the open or unreserved category. And this is providing a weaker benefit compared to the over and above implementation. In fact, as we saw in the example, it may provide no benefit at all if the target minimum is already reached in the absence of the reserve. So you might prefer a minimum guarantee implementation if the reserve is as a protective measure. Okay, and there's some examples here that I won't get into. Let me make one other quick theoretical observation and then move on to some of the policy development. So there's much more in the paper that I didn't have time to get into in terms of the modeling, but there is a important drawback of sequential reserve processing that we explore, which is it may create efficiency loss, okay? And it's easiest to see this in a situation of hard reserves. So in my example here, I have one open unit, unreserved unit, and one essential personnel reserve. The underlying baseline priority pi u places patient I1 ahead of patient I2. And patient I1 is essential personnel. Okay, so let's think about what happens if we allocate the open unit first. What happens is patient 1 under the baseline priority is the highest priority patient. So the circle for patient 1 is now gray because they will be allocated the open unit, okay? And in this example, it's an example of hard reserve. So we had a vacant essential personnel reserve. There's no essential personnel left, okay? So we end up with an idle unit, okay? If instead we had reversed the order of precedence and allocated the essential personnel unit first, then patient I1 would take that unit, okay, freeing up patient 2 to take the open unit. Okay, so we have different numbers of patients being matched. Here we have a maximal match because both patients are matched, whereas under the open reserve processing, we have that idle unit, okay? So what we do in the paper is investigate what we call smart reserve policies that help us avoid efficiency loss by avoiding the myopic assignment of patients to categories. Okay, so I'll say a matching is maximal in beneficiary assignment if it maximizes the total number of units awarded to target beneficiaries of categories. Okay. So this is an axiom. I didn't write out the mathematics here, but together with our assumption of non-wastefulness, maximality in beneficiary assignment gives us Pareto efficiency. And the high-level idea of our smart reserve policies is basically to determine which agents should be matched to some category in a greedy way, following the baseline priorities, all the while assuring that we are getting the maximal assignment, maximality in beneficiary assignment. Now, there's still not a unique way to do this, and so there's many ways to do this. And what we show in the paper, sorry, I don't have the time to get into the details, is the same kind of intuition about minimum guarantee versus over and above applies to our smart reserve concept here. So if all unreserved units are processed at the end, then the algorithm that we propose generates a minimum guarantee version, whereas if all unreserved units are processed at the beginning, then our algorithm generates an over and above version of these smart reserves, okay? So let me press ahead and at this point, you might be saying, okay, what happened to pandemic rationing? Who cares for all of this math, right? And this allows me to pivot to some of our interactions with groups in charge of designing these guidelines and tell you some stories about that. So I wanted to first start off with some conversations that we've been having over the last 9 months or so with disability rights advocates groups. Okay, so I mentioned several states had very strong positions about disabled patients, and these were challenged. They were Office of Civil Rights challenges. So some lawyers who specialize in this got very interested in reserve systems as a way to get to some middle ground between one camp in the disability rights community that said ventilators should only be randomly assigned. Okay, so Deborah Hellman and Nicholson talk a little bit about the difference between over and above and minimum guarantee implementation. So they say a reserve can be operationalized in either of two ways. It can provide a boost for a group, as might be justified in the case for healthcare workers. So they're articulating a view of an over and above a reserve for healthcare workers, or it can be function as a protective measure to ensure that members of a group are not left out altogether. Okay. So they go on to say, if the reserve category is processed first, it functions as a protective measure. And if it's processed second, it functions as a boost. In our view, and consistent with the American with Disability Act emphasis on equal rather than superior opportunity, the reserve for disability should function not as a boost, but as a protective measure or as a minimum guarantee. Right. So the article goes on to talk a little bit about SOFA type scoring. So this is, the kind of legal interpretation in terms of the ADA. I'm not an expert on what the ADA actually says. So let me briefly say, our work on reserve systems, it's kind of a natural evolution. There was work thinking about implementing diversity policies and school assignment. Typhoon Sonmez has been a very prominent person working in this literature. So he has a very exciting paper about reserves used in Indian affirmative action, and the Boston and H-1B examples I've been talking about are coming from papers that we've done with others. Okay, so let me spend the last 15 or so minutes talking about the path between theory and practice. Okay, this has been fun. This has been frustrating. This has been informative. Kind of the high level thing I want to convey to the crowd here is I think there are large returns for economists interacting with medical ethics communities, and our experience with this has been, I would say, overall quite positive, because the analytical toolbox that we bring to the conversation is something that these groups have not had historically access to. Okay, so I mentioned this article by Zeke Emanuel and others that came out in March 2020, describing these different ethical principles, and our basic reaction to this was, they have all these goals. They're talking about an allocation mechanism. Economics is the study of the allocation of scarce resources. Why are there no economists or operations researchers or computer scientists part of these groups? Okay. And by and large, these groups are articulating values, but they're not thinking about the implementation of those values through an allocation mechanism. Okay. So, what we were doing around that time, together with Typhoon and Utku, we were working on a book chapter on reserve systems, and started to read these guidelines. So I talked about the New York and Minnesota debate that led to the abandonment of essential personnel. And we wrote a first version of our paper. Maybe we wrote that version a little bit too quickly. We put it out in April 2020, proposing the idea of a reserve system. Okay. And 2 days after we circulated the first draft of our paper, Massachusetts announced the ventilator allocation guidelines. Okay, I mentioned something was not quite right about that. Even though the announced priority points system did not have any priority points for medical personnel, the Boston Globe headline suggested otherwise, okay? Preference given to medical personnel. And the culprit for this confusion was an informal referral to heightened priority that I've just talked about. And so that made us think that the group in Massachusetts may have faced a similar challenge as the groups in New York and Minnesota faced earlier. And I have strong indications that that's the case, nothing that I can point to, but the reason I suspect that is we soon after reached out to Bob Truog. Okay, so Bob Truog is a bioethicist who teaches at the Harvard Medical School, who was a member of the committee who mentioned that the committee struggled with essential personnel. They didn't know what to do with essential personnel, and conceded that the guidelines were vague on this. Bob Truog, is someone who also wrote an article in that same issue of the New England Journal of Medicine. And he was a delightful collaborator because he said, we don't have access to the toolbox that you guys have as economists. So we told him a bit about the reserve idea, and he said, why don't we team up with Govind Prasad, who is the second author of the Zeke Emanuel article, and Douglas White, the father of the multi-principle priority point system, to try to get this idea in the medical ethics community, okay? So what we've been working on since March, since April, is with Bob Truog, Govind Prasad, Doug White, Typhoon, and Utku. We have learned a lot about bioethics and this broader community, and introduced the reserve system idea to these communities. Bob Truog in particular said, don't call it a reserve system, call it a categorized priority system. So we have an article in a journal for clinical care medicine talking about categorized priority systems. We've also had the opportunity to interact with a bioethicist named Harold Schmidt. So he's one of the leading advocates of using rationing guidelines to both acknowledge historical disadvantage in access to medical care in the United States and doing something to remedy that. Okay, so he has written several articles in popular outlets and in medical journals about the urgency of using rationing guidelines to remedy inequity. And the first concrete outcome of our collaboration was a design of a rationing scheme used for remdesivir. Okay, so that is an antiviral that was in scarce supply in May and June in the United States. So the Department of Health and Human Services awarded units to states. There wasn't enough production, and remdesivir was seen as a promising antiviral. The evidence since then has become much more mixed, and the community engagement that took place was led by Doug White, the physician at Pittsburgh Medical Center. And they established 3 reserve categories based on whether a patient is from a hard-hit geography based on an index of disadvantage called the Area Deprivation Index, whether a patient is essential worker. So to Ron's question about how do you define an essential worker, they use the Pennsylvania state definition, okay? And then finally, a reserve category based on whether a patient is expected to die in 1 year based on comorbidities, okay? Now, at this time, there was not much information on the effectiveness of remdesivir. So the priorities that this UPMC folks decided on was based on a lottery. Okay, so this is a situation where the reserve system simplifies this to a stratified lottery, and it amounts to a boost, a 25% boost in the odds of getting remdesivir if you're from a hard-hit geography or you're an essential worker, and a 50% reduction if you are expected to die in 1 year. So this was used in May and June, and actually in July. We just got some of the data from this system. It looks like about 300 patients went through this system. In the end, I think about 30 patients were denied the drug because they didn't have enough units. And Utku Anver's Excel spreadsheet is what was used, his Visual Basic macro, to actually allocate these units. So that was quite interesting and stressful. So that was March, April, May, June. At this point, remember, we had no knowledge that a vaccine was coming, right? The miracle that we had actually several vaccines, but the rationing community's focus had shifted to thinking about vaccine rollout. And the debate about vaccine rollout throughout the pandemic has been equity. And so the CDC commissioned the National Academy of Sciences, Engineering, and Medicine to devise a framework for the equitable allocation of vaccines. That group announced a framework through a preliminary document in September 2020. And this document focused on the structure of priority tiers. Okay, so they are working solely under a priority system, very much modeled on previous influenza vaccine guidelines. Now, in the background is this debate about prioritizing disadvantaged communities. So Melinda Gates, who has bankrolled a lot of vaccine production efforts, especially internationally, said, we care about getting this vaccine out equitably. The first people that need this vaccine are the 60 million healthcare workers around the world. They deserve to get it before anyone else. Then you start tiering. In the US, that would be Black people next. Quite honestly, and many other people of color, they are having disproportionate effects of COVID-19. Now, you can imagine this was a very controversial debate. On the left are some articles about should people of color get access to COVID-19 vaccines before others. This is something that was debated by the national academies. And on the right is someone who's strongly opposed to assigning a coronavirus vaccine by race. Okay, in July of 2020, the CDC and NIH commissioned National Academy's report, bringing together a committee of distinguished experts. I will say experts from the medical ethics community, but not experts from economics. So this is, what I hope for the next pandemic, we can play a larger role in this. And they put out a system based on priority tiers. Okay, so the system in September 2020 had 4 phases: a jumpstart phase with high-risk health workers and folks with comorbidities. Phase 2 are teachers and people in congregate settings and moderate comorbidities. Phase 3 are younger adults and children. And then phase 4, which what we are in the United States right now, everyone else who did not have access. And what they say at the bottom of this graphic is equity is a cross-cutting consideration, okay? That in each population group, vaccine access should be prioritized for geographic areas identified through the CDC's Social Vulnerability Index or another more specific index. So they put this draft document out and solicited public feedback. Our collaborator, Harold Schmidt, who's a member of these communities, pressed the committee to be precise. What do you mean about equity? How are you going to operationalize equity? And we were aware that the committee was struggling with this. So a few weeks earlier, we actually circulated a paper with Harold Schmidt showing exactly how to operationalize something like an index of disadvantage through a reserve system. And so this was brought to the attention of the committee. Around the same time, Zeke Emanuel and Govind Prasad advocated using a reserve system for vaccine allocation in the United States, writing, for instance, half of the initial allotment might be prioritized for frontline health workers, a quarter for people working in high-risk settings. Such a categorized approach would be preferable to the tiered ordering previously used for influenza vaccines. Okay. And it's hard to understate the influence of Zeke Emanuel in these conversations. So he wasn't a member of the NASEM committee, but the NASEM committee strongly leaned on his New England Journal of Medicine article and this JAMA piece, and eventually recommended a reserve system. Okay, so this was just a recommendation. What they stated is we should use a 10% reserve for people from hard-hit areas. We don't propose an approach in which within each phase, all the vaccine is first given to people in high SVI areas. Rather, a reserve 10% proportion of the total federal allocation of COVID-19 may be reserved to target areas with a high SVI, and that's defined as the top 25% of the SVI distribution within the state. Okay. Now, these were recommendations, these were guidelines. In the United States, Operation Warp Speed actually allocated vaccine doses proportional to state population. Okay, so I think that was in part a political decision. They did not want to be seen to be favoritizing, certain states. So even though measures of disadvantage differ strongly across states, the initial allotments for the first several months were proportional to population. And states were free to propose their own guidelines. The CDC required each state to issue a guideline posted on their website. And Tennessee was the first state to adopt a reserve system following the NASEM guidelines. So here is an excerpt from their vaccine allocation plan. So you see they're using the same exact language as the NASEM group. It was a 10% allocation for hard-hit areas using the SVI. So what that basically amounts to is in Tennessee, so we interacted quite a bit with Michelle Fiscus, who's a state Department of Health official there. They take the allotment from Operation Warp Speed, okay, then they distribute it to counties within Tennessee. There's about 80 counties in Tennessee, and they dial up the allotment to counties that have high SVI. Okay, so that's the operationalization of this. Seeing this and seeing that a vaccine was on its way, we put together an event teaming up with Ariadne Labs. So that's the group led by Atul Gawande, who was advising the Biden administration, and the UPenn Department of Medical Ethics and Health Policy. And what we learned in doing this is, this is a community that's very different than the economics community. And it was very valuable partnering with our friends in public health because they brought actual allocation planners. And in particular, the group from Ariadne Labs brought the reserve system idea to Massachusetts individuals in charge of vaccine allocation. And we had an opportunity to interact with the California Surgeon General, Nadine Burke-Harris. So we introduced the idea to these two groups. In Massachusetts, the initial vaccine plan had a 20% reserve. So it's twice the reserve size of the NASEM recommendation. They did this as an over and above implementation initially. California's state guidelines, they preferred the term categorized priority system. So they described this reserve idea where they didn't use the index of disadvantage, the social vulnerability index. They used their own index called the Healthy Places Index. And it amounts to a 40% reserve for disadvantaged areas. So this is what was announced in March. And several other places have adopted reserves of various forms. So we have some more details on that in our paper. We actually set up a website to share kind of best practices across locations on reserve systems. I'm running out of time, so I want to just tell you about one last thing. So most of this was about vaccines in terms of policy successes that we've had. There has been some movement in terms of other scarce resources. So monoclonal antibody therapy is among the most successful treatments for COVID. So it's more successful than antivirals. Basically, you infuse or you inject antibodies from patients who recovered from COVID into those who have recently tested positive for COVID. It's extremely scarce. And in Massachusetts, they assembled a working group to advise on the equitable allocation of monoclonal antibody therapies after the FDA issued an emergency use authorization in late November. So a member of the working group, Dr. Emily Rubin, who works at Mass General, reached out to us and said, this seems like a great opportunity to use a reserve system. And that's in fact what the state decided to do in November. So the details on the reserve system are here. There's an open allotment. They talk about 80% of available doses are open to everyone. And then 20% of the doses are awarded to patients who live in a census tract with high SVI. Okay, so let me wrap up here. I think I'm out of time. So, what I want you to take away from this is, we all hope that we never have to use these schemes ever again because there's no scarcity. But the designs of these schemes created a lot of pushback because they reflect a statement of values. Okay, so the lawsuits against certain criteria, disadvantaged groups using race, disabilities rights groups. There was a concern that some of these groups said is that we don't matter enough, right? So we're not being represented. So I think finding the right mechanism is important to arrive at a balance. And a reserve system we think allows for more flexible alternatives than the simplified priority system. So we hope we've succeeded in getting this into the conversation with the public health and medical ethics community, but there are still many questions that remain. We're now starting to get some data on the actual functioning of these reserve systems. I just mentioned the remdesivir data. There's also some theoretical questions that remain about smart reserves, about reserves in dynamic allocation problems. And so there's a lot more to be done on that. So let me stop here. Ellen, I think I'm right at time, right?
Yes. The second. So first, thank you very much, Parag. I think we are at time, but since it's we'll go a little bit over time and allow for some questions. So I see that many people want to ask. Ron and Benjamin, I think you didn't have a chance to ask yet, so please.
I just clapped my hands.
Benjamin, you would like to ask a question, Benjamin?
I've already made one. Thank you.
Ron, you would like to ask a question?
Yeah, I enjoyed the talk, Park. Thank you very much. But I'm left a bit puzzled, right? Because typically, when we as quantitative analysts approach a problem like this, we define some objective criteria which we want to maximize. We have some constraints, and then we work within this model and try to do something which is optimal, maybe semi-optimal or whatever. Here, there was no objective criteria. You did not mention what is the goal of the whole thing, and that's also part of the debate. So I'm not sure the bottom line, what is the real contribution apart from introducing yet another way of thinking about rationing into the toolbox of rationings? What can we say something about what it improved? Did it do better? So I find it a bit puzzling. And in that context, let me say that, if I were to think of a criterion, I would probably think in social terms. So we would like to find the optimal subset which does something, right? Yet all the rationing procedures before you came into the discussion were on an individual level. So each individual gets a point, some score. And of course, you cannot do social optimization where each individual gets a score.
Yeah.
So I'd like to hear your comment on that as well.
Yeah, no, I think it's a fair comment, Ron. We're kind of coming at this very much from a market design engineering point of view. So we came to this problem saying there's a priority system. Here's a more flexible alternative which simplifies to a priority system when there's just one category. Now, tracing out kind of the frontier of what can be done with that versus other systems is, I think, still an open question. And there's some new papers that are trying to think a little bit about that. So that's something that Matsushima just put out a paper about 2 weeks ago, and I haven't fully digested his answer to that question. But I think it's a very good question. In terms of the objective, I think one lesson I've learned from interacting with policymakers here and the bioethicists here it's hard to get them to articulate a simple objective, right? So when it's something like our goal is to minimize the number of lives lost, then I think our constrained optimization frameworks are very useful to think about that. But usually you have all these stakeholders competing and saying, well, we need to make sure disabilities rights advocates, are getting a fair share. Disabled patients are getting a fair share, or we should protect the interests of those who are disadvantaged, minority groups that cannot socially distance. And the places that we see reserve systems deployed in the field are often those where it's not easy to articulate a simple objective function. So that's kind of why we haven't pursued that question very much. I think it's a fair question, though, Ron. I think it's an interesting question, tracing out exactly the possibility set from a reserve system versus, the simpler priority system. So that's kind of work to be done.
So does vagueness so when you call flexibility, so are you suggesting that a system which can answer every political group and say, well, we've accounted for you in some way, because it's so complex, that would be a good system, because that would kind of hush down some political noise?
To be completely frank, I think that's a part of this, Ron. So if you go back to the prioritization based on race, right? So there's a group that says, Black Americans are dying at 1.4 the rate of whites, so that we should give them higher priority. And there's a group that says, no way, that's, discriminatory on the surface. So what's a compromise? A compromise is maybe we have prioritization for a subset of the units. It's very similar to why we see reserves in like school assignment. There's a group that says we should assign children to schools near where they live. There's another group that says, no, that's not fair, because the families that are living in nice neighborhoods are going to get better access to schools than those who don't. So what do cities do? They end up at compromises where it's, some kind of bargaining game right in the background. That's, maybe a way to think through this. Where, it's common to see a 50-50 split. Okay, somehow that's salient. We're going to reserve 50% of the seats for kids from the neighborhood and 50% for seats outside the neighborhood. So, one thing that article for the disabilities groups that I quoted from talked a bit about that I didn't show you is the idea that everyone should get a chance. Okay, so if you have strict prioritization, it could be possible that we have many realizations of the problem where there are certain patient groups who will never get allocated a ventilator. So an idea that they were interested in is, well, why don't we have a 10% reserve where it's random assignment? So that way, to your point, Ron, we can go to certain groups and say, look, you at least had a shot. It's not like we're saying society says you don't matter. You had a chance. It could be a very small chance, but in a priority system, it would be very clear you had no chance. We didn't care for you. Okay, so this is literally the debate in Alabama with severe forms of mental disabilities. That was the court case that the Office of Civil Rights said you cannot do this. So in response to that, we could use the flexibility of a reserve system.
Well, I find it admirable that you guys pursued this. Thank you very much.
Parag, if I may, just one. I realize we're running out of time, but one thing that I wasn't clear about is really why you cannot, this kind of considerations, like you want to favor a disadvantaged group, say, take your school example. So you could give, in the initial priority system that you described, where there were some criteria and you got a point, some number of points according to, for each one of the criterion. Yeah, the life cycle, I forget right now the others. Okay.
Save the most lives,
so,
yeah.
So, you could get a certain points for being disadvantaged, okay? So, yeah. And that would be, factored in with other characteristics that you have. such as your merit. So there is a way to take account, as far as I can see, of the interest in favoring a disadvantaged group in also the original and multiple priority scheme, where you give some points for each consideration that you consider as relevant.
Sure, absolutely right. So I think the point, maybe it's easiest to see the point that we're trying to make with the essential personnel idea, right? So, if we give points to essential personnel, as New York and Minnesota pointed out, when there's uncertainty, and I think the real resolution to this question relies on some uncertainty, we could have a realization of the problem such that they take all the units, and that is not acceptable. So if you give points to, kids from the neighborhood, it could turn out that they take all the seats. So what reserves allow you to do is protect yourself against those extreme scenarios. I think the fact that they say we have heightened priority or we have these tiebreakers but don't spell it out shows that these committees struggle to figure out exactly how to calibrate the points. So if we had enough data, if we had some measures of how much uncertainty we should expect, you're absolutely right. We could try to reverse engineer a priority system that does that, but a reserve system kind of does it more directly, we think, and protects against these extreme cases.
Yeah, I see that. Okay. Okay, Eric, would you like to? We are basically out of time. Would you like to?
Well, I just like to thank Parag and all the other speakers for making this a most worthwhile summer school. It's not the way we would like to hold our summer school, but under the circumstances and given the topic, I think it was most appropriate and worthwhile. And let me invite everyone back for an in-person summer school next year.
So thank you, Eric. I'd like to join that. I think it was very interesting. Thank you all, the speakers and the participants, for joining us and coming into this event. I found it. I feel I've learned a lot, and yes, I'd like very much to see you in present here in Jerusalem next year. And I'd like to thank again Eric for planning this wonderful program that you, the speakers, made it happen. So thank you very much, and hope to see you here at some point.
Thanks to everyone at the Institute who did all the organizing.
Thank you.
See you next year.